we're going to go into a Q&A session specifically around this pediatric and adolescent note sharing topic. And then after that section, we're going to go to the next presentation. So we're going to spend the next, say, 10 minutes on this. And what Amanda's going to do is she's going to try to unmute everyone. Hold up. Before she does that, make sure your phone is muted, or if you put us on hold and there's background music, you turn that off in some way. So we're going to try to unmute everyone. If it's chaotic, we'll mute you all and you'll raise your hand. So we're in this together, okay? All right, Amanda, please unmute everybody. Okay, there's no chaos yet. Good. Okay, all right. Well, I want to open it up to Q&A. I have questions, but I want to have everyone else as a guest. Feel free to weigh in first. So reactions, go. Nobody wants to be the first one, by the way.
So I see a chat note from John regarding the differences by ethnicity, and we did not see any differences there. And we had about 20 Hispanic, so out of our 55, so it's a really quite good group, and we did not see any differences. I did not look by language in terms of Spanish speakers or not, but I'll tell you the majority of our adolescents seen in our chronic care clinics actually speak English there, so I couldn't say that we had any Spanish only. They were probably bilingual if we kind of did sample them, so can't speak to that.
This is Stacy. I have a question. First of all, I have a statement. Thank you, guys. This is fantastic. But Jeannie, I have a question for you on one of the last slides you presented. You mentioned that I think it was between 62 and 67% of adolescents agreed with what was in their notes, and only 7% dissented, for lack of a better word. Was that additional like 30+%, were those individuals who just didn't open them, who didn't have a vote, who?
So these are all patients. We gave these participants, all of them saw their note. The 7% was if they wanted to edit that note. And so that's what they were asked. They were wanting to say, oh, I wanted to change something in the note. And what they asked to change was their, oh, I'm not taking that medicine anymore, or I'm not allergic to that medicine. So it really wasn't about generally any other issues that they were bringing up. And the rest of them were fine with the note as it was. I forget your other question. So in terms of the percentages, about 62 and 64%, that was in regards to agreement with the physician readers. So in terms of trying to measure some measure of comprehension, we wanted to see how they were doing because I think, the other questions that we had were really self-report, right? Did you understand, were you satisfied with the note? Did you want to change it? Did you understand your health status? Did you understand that a medical change occurred or not? I mean, we needed to compare that to some sort of standard. And so what we did was we had, independent physician readers read the note and see kind of what they thought of that note. It's interesting, actually, if you look across the board, adults or, the children or the, AYAs, there really wasn't any 100% consensus. They all didn't 100% agree one way or the other, which actually I think speaks to kind of some communication issues sometimes when we just communicate with each other by word. So I think there's that kind of noise as well. But overall, I think actually, I think this speaks to kind of most people have a perception that these young adults and adolescents will not comprehend their note at all. And I would say that this data actually argues against that.
Thank you.
I'm just going to interrupt and say, so everyone is unmuted. If you want to mute yourself for background noise, feel free to now re-mute yourself, but everyone's welcome to keep yourself unmuted. We got a number of great questions here in the chat box. And I think many of these are directed to you, Jeannie, or just everyone, feel free to respond. But let's see here. So Tammy Flynn asks, I was curious about having parental consent for sharing with adolescents. Maybe she means, how does that work? And then Brent Steinecker asks, I'm also curious about whether it was hard telling patients you'd share the note with the team, but not with the parent. And so I'll kind of leave that there. There's another question after that. I'll rephrase that. I don't think I read them as questions. Maybe so. All three of you.
Well,
I think
hey,
yeah,
Liz,
please.
I'm happy to pipe in. Just
Please.
So my experience at Boston Children's is that I still have access to my 14-year-old's notes. My understanding is that at age 12, is that correct, Liz? she could get her own portal access, but that I will still have access to her notes. But that's how Boston Children's does it. That's not how Stanford or Rady does it. So.
Stanford, Chethan or Cindy, do you guys want to chime in on how it's working in California with you guys?
I think to both those questions, Betsy's correct. The parents aren't getting the notes, but the teens are. As to the question about, Jeannie can answer about telling the patients in her study that they were going to see the note, but not the parents. I'll defer to Jeannie, but in general, our parents are unhappy with the patient portal access for our youth ages 12 to 17. And so we're working, again, it goes to Chethan's points about the granularity available to us and making sure that we're protecting what we need to protect, but allowing what should be shared, and we're highly aware, and our Family Advisory Council is making this very clear, as well as many parents of children who work here, whose children are now adolescents and seeing what they can see. So we know we've got to change our settings. As to the workflow about getting consent, I can share that. I don't have the exact workflow, but for the teen to be allowed access, the parent has to consent for them to get the access code. And if somebody would like more clear workflow about how that happens, I'd be happy to share that.
Thanks.
And at Stanford Children's right now, from 12 to 17, both the parent and child see this relatively the same information, but it's very limited. So no notes are shared between 12 and 17. As I mentioned, we're trying to figure out some of the challenges around granularity and the challenges around, even if you did have that granularity and a teen's note had more information than the parents, and a parent had the login for the teen's portal, then that can present issues as well. So we're exploring those. Another thing that we talked about was, should we think of, instead of thinking of 12 to 17 as one group, maybe 12 to 14 would be different from 15 to 17. So we've talked about splitting up the adolescent group, whereas the younger children might be more dependent on their parents for help in managing certain things. But it's not necessarily an easy or simple kind of age-based determination. So it's a conversation that we've had around that, instead of thinking about 12 to 17 in one group. But for now, for 12 to 17-year-olds, there are no notes that are shared at the moment.
Chethan, since you're answering questions, earlier while you were talking, Deirdre Steve asked, what version of Epic are you on that allows the clinicians to view which notes are being read?
Oh, so I think that doesn't necessarily have to do with the version of Epic itself, but it's about building an additional column. That was a lot of some custom work that our team, especially Adam Hogan, did to build in, where he was able to take the, in sort of the backend database, there's a marker of whether or not a note was shared and then whether it was viewed. And it's about taking that and customizing it to where you could build it into the clinician view. So it was a lot of custom work that we did.
Okay. Yeah, there was a recent Epic webinar specific to OpenNotes where like 120 different individuals attended to talk about the technical aspects of Epic for OpenNotes. And that was something that was shared there as a possible thing you could add on to the EHR.
Yep. So this is Jeannie. I wanted to address some of the questions that were out there about patient education in regards to medical charts. And so one of the approaches that we've taken here at Rady Children's, particularly for us in the GI clinic, and I run the inflammatory bowel disease clinic here, is really doing a transition program where we take kids 12 and older every year and really assess where their health literacy is, and then give them all the resources they need to improve that health literacy over time. And I think that approach is actually quite helpful in terms of taking all of those kids through those developmental and, cognitive growth as they kind of what types of information can they digest, and then how to digest that over time. And so that gives us like openings for conversations in regards to privacy and kind of other issues in regards to how do I understand my labs, and sometimes some of the medical jargon that we use. So it gives us a period of time that we can talk about that at each visit kind of over time, so it's not kind of all consolidated into one. And so I think that helps people to really begin the health literacy journey that they need to in order so that kids can be ready when they become adults. And it's interesting because sometimes when I do kind of join conversations with other adult providers, obviously, unfortunately, we also suffer from health literacy in adults. The truth is that just because you're an adult and you've hit 18 doesn't mean that you're health literate. And so I really do believe that these resources, which again are tailored to young people, can be also used for adults as well. And so I'm trying to kind of move towards that in terms of getting my colleagues on board, because sometimes they won't come on board for transition, but they might come on board for health literacy.
Nice.
Hey, this is John. I'll pose a question to the folks still on, if that's okay, Liz.
Absolutely.
So you all, the Office of National Coordinator is moving forward with redefining terms related to health information, really based on the 21st Century Cures Act and interoperability. And in his definition, notes are included, which makes sense to me. It's hard to imagine we can be interoperable and not share notes. But then that raises the issue of, especially when it comes to adolescents and especially when it comes to parents, I think, access to information, what's going to fall under the ONC's definition of information blocking? Even, those terms, which I think those terms actually come from the 21st Century Cures Act, say something about how, keeping information from a person is going to be viewed. So, the discussion we're having about should adolescents have easy access to their information, and when should parents have it, and when should they not? We're on the verge, I think, of probably a couple-year discussion around those issues.
So, hey, this is Natalie Pagler at Stanford Children's. This is, I think, a really fascinating conversation, and I totally agree that we're on the verge of a couple-year conversation, as you said it. I'll say where one of the places that we're trying to struggle with this is even with the Meaningful Use 3 patient-facing API, so that patients can download their data. There are real challenges with doing this in pediatrics. So one of the most common platforms for downloading your data with that Meaningful Use API is the Apple Health Record, and yet right now there are no children's hospitals participating because for multiple reasons. Because and on both sides, I would say, from Apple and from the children's hospitals, and it really gets to these questions of how do you protect adolescent confidentiality? How do you handle multiple patients on one device? How do you handle proxy access? And yet, we're at a point where we'd like to at least open up to our greater than 18-year-old patients, if we have quite a few, and yet we're worried about the risk of information blocking. So I think we've got some really challenging conversations coming up to sort through these issues, and also need to get the government thinking about this, because right now they're not addressing the pediatric specific issues at all.
Right. I mean, when I look at their definitions of information blocking, none of them say anything about adolescents specifically, or children, or parents. They're very general. They might be argued to apply in some circumstances, but I don't know. You know, I would assume, for example, there's the first information blocking they give an example of is harm. Anything that would cause harm can be blocked. So all notes about child abuse and domestic violence, I would assume, would fall under that. But after that, I'm not sure.
I'm going to put my patient hat on, wear many of them, but unfortunately, I don't think we have anyone from Kaiser Permanente who's still on the call, but you know, you might know that Kaiser's in Southern California, and then pretty much everywhere else around the country do share notes with patients. Kaiser Northern California does not. As a former Northern California Kaiser patient, which I still love them, I just no longer have Kaiser as my health insurer, circumstances. And when you're not a Kaiser member, because they're both the payer and provider all in one kind of a health system, when you're no longer a member and you don't have health insurance through them, they kick you out of that patient portal. They know you're not a member, so you can't log in again to read your emails, they're afraid you're going to email them when you're not a member or something. And so you can't see your old after visit summaries or anything unless you do a full medical records request. I'm interested in how they're going to handle information blocking, because they're already doing it. And at a certain point, you know, if you know, in 2 years from now or whatever, if that becomes the law of the land, are they ready for it? And I don't know. I mean, they're already information blocking. Of course, I've done a full medical records request and read all my doctor's notes because I'm that kind of a nerd. But I was just throwing that out there in case anyone from Kaiser happens to still be on this call.
Is there any law, this is Jeannie, is there any rules about, you know, if you've ever been seen at an institution, then you can access your records for whatever period of time, or is this just kind of being all made up now?
John, I don't know if there's any law, but I am now a UC Davis and UCSF patient, and they would know if my health insurance changed, it wouldn't change anything about my access to those portals. Like, they don't care as long as I could pay my bills. And if I stopped going to, say, UCSF because I don't want to drive there anymore, they wouldn't know I was never coming back. So I think as long as that portal account is still active, I can keep logging into it in some way. So but I have no idea about loss.
Yeah, I don't know. You know, I think in the old days of paper records, you could destroy paper records, I think, after 7 years. Because of course it was enormous expense and space to house all of these things, and but I don't know about electronic records. They're obviously easier to save, and you know, it seems to me it's fairly easy to let people keep coming onto the portal. So I don't know.
Brent left a comment. And he's still here, so feel free to say it, but I'll read it. He said, I spoke to the ONC attorneys at HIMSS last month, and they encouraged everyone to comment on the rule, include those scenarios, for example, teens, domestic abuse, etc., and any thoughts or opinions around those scenarios.
Yeah. This is Chethan again from Stanford Children's. Going to John, your question about what could be considered harm, and to some of the issues that Natalie raised about granularity. I think it starts to become tricky to define, because each state has different laws and scenarios. But you know, you could imagine a situation where an adolescent, if depending on the situation they're in, they could be in a household where if a parent found out about them being on birth control, that might lead to a personally dangerous situation for them if that was something their parents did not agree with. and obviously every state is different, and not all situations may be so extreme. But I think one of the things, we need to figure out a way to have more granularity in separating this information out. And one of the other observations too that I've noticed is that in most of these conversations that happen, whether it's at the level of the hospital, at the level of meetings like the California OpenNotes Consortium, or people commenting, it's often parents who comment. There's very few teens who are actively involved in commenting on what they would like, what their rights are. I know there was a paper that recently came out about parental perceptions of teen informations in portals, but not as much about teen perceptions. And I remember at UGM, at the EPIC conference a few years ago, there was a group from Ohio that was there, from one of the Ohio children's hospitals, and they said when they reviewed the Ohio case law, saw there was cases of parents who had sued hospitals because the hospitals would not share teen records, but there was no cases of teens suing their parents to keep records private. So the hospital decided to go on the side of the parents, but not accounting for the fact that it would be much more rare and unusual for a teen to be empowered to sue their parents. And so I think, in the spirit of teens, adolescents being a more vulnerable patient population and not being able to advocate for themselves in the same way, the same voice, I think it's really important for those of us who have the power to shift this policy, that we do our best to actually consider the perspectives of teens in whatever way is possible, and to bring their perspectives in more